I will be comparing the hemodynamic effects of epinephrine, norepinephrine and dopamine. So before that, it is important to understand the baroreceptor reflex mechanism. So what is baroreceptor reflex mechanisms? Arterial blood pressure is normally regulated within a narrow therapeutic range with a mean arterial pressure ranging between 85 to 100 mm of mercury in adults. This is accomplished by baroreceptors that act as pressure sensors and can sense changes in arterial blood pressure. The baroreceptors are located in the wall of the carotid sinus at the bifurcation of the internal and external carotid artery and in the wall of the aortic arch. The baroreceptor reflex system comprises of negative feedback systems that helps to stabilize arterial blood pressure and maintain homeostasis. So how does it maintain the blood pressure and homeostasis? When there is a sudden rise in blood pressure, there is stretching of the arterial walls. The stretching of the arterial walls sends signals to the baroreceptors resulting in activation. Activation of baroreceptors generates impulses at a frequency which is higher than normal. There is increased firing frequency and the impulses are transmitted via 9th and 10th nerve to the vasomotor center. The vasomotor center inhibits the sympathetic system and activates the parasympathetic system. The inhibition of sympathetic system results in reduction in heart rate, the contractility of the heart, reduced cardiac output, vasodilatation and a fall in blood pressure. Activation of parasympathetic system releases acetylcholine which reduces the heart rate. So both sympathetic system and parasympathetic system acting in the same direction helps in lowering the blood pressure and restoring the blood pressure to normal. So what happens when the blood pressure falls? A fall in blood pressure results in reduced activation of baroreceptors. So there is decreased firing frequency and this leads to activation of sympathetic system and inhibition of parasympathetic system. So activation of parasympathetic system increases the heart rate, contractility, conduction velocity, increasing the cardiac output and the rise in blood pressure. There is also inhibition of parasympathetic system and activation of sympathetic system and inhibition of parasympathetic system helps to raise the blood pressure to normal. So in this way, baroreceptor reflex mechanisms helps to stabilize the blood pressure, restore blood pressure to normal and maintain homeostasis. So what is the effect of epinephrine on diastolic blood pressure? The smooth muscles of the peripheral blood vessels have alpha-1 and beta-2 receptors. The stimulation of alpha-1 receptors causes vasoconstriction and increase in peripheral vascular resistance, while stimulation of beta-2 receptors causes vasodilatation and a fall in blood pressure. So stimulation of alpha-1 receptors increases the blood pressure and stimulation of beta-2 receptor causes a decrease in blood pressure. So the overall effect on diastolic blood pressure is either there is no change in diastolic blood pressure or there is a slight decrease in diastolic blood pressure. So the next is what happens to the mean arterial pressure. The mean arterial pressure is calculated by diastolic pressure plus 1/3 of pulse pressure. So since the systolic blood pressure increases and diastolic blood pressure decreases, the mean arterial pressure slightly increases. So what is the effect on heart rate? Now we have discussed the baroreceptor reflex mechanisms where the baroreceptors respond to changes in arterial pressure. So a rise in blood pressure is accompanied by a fall in heart rate. Since the mean arterial pressure slightly increases, there are not much changes in the baroreceptor function. So what happens to the heart rate? The heart rate increases. This is because epinephrine is a powerful cardiac stimulant. It increases the contractility and thereby increases the heart rate, stroke volume and cardiac output. So the effect of epinephrine administration is an increase in heart rate. So the net effect on blood pressure is a rise in systolic blood pressure which is due to increase in cardiac output, a fall in diastolic blood pressure This is because of the alpha 1 and beta 2 effect which counterbalance each other. The mean arterial pressure slightly increases and the heart rate increases. So the next effect, epinephrine shows a biphasic response in blood pressure. Injection of epinephrine causes a sudden rise in blood pressure, and this rise in blood pressure is due to alpha 1 and beta 1 mediated effect. Alpha 1 causes vasoconstriction and increase in peripheral vascular resistance, and beta 1 receptor stimulation increases the heart rate contractility and increases the cardiac output stroke volume, thus increasing the blood pressure. So initial rise in blood pressure is due to alpha 1 and beta 1 mediated action. As the epinephrine concentration in the plasma decreases, the effect of beta 2 receptors is unmasked because beta 2 receptors are more sensitive to lower doses of epinephrine. So beta 2 receptors cause vasodilatation and a fall in blood pressure is seen. So as the plasma concentration of epinephrine decreases, the beta 2 effect is observed. So epinephrine causes an initial rise in blood pressure which is due to alpha 1 and beta 1 mediated action, and this is followed by a subsequent fall in blood pressure which is due to beta 2 mediated vasodilatation. This is known as biphasic response. Because the initial pressor response is followed by a depressor response. So initial rise in blood pressure is followed by a subsequent fall in blood pressure, giving a biphasic response. So what happens when an alpha blocker is administered prior to epinephrine administration? Alpha blocker blocks the alpha adrenergic receptors, thus abolishing the alpha mediated pressor response or alpha mediated rise in blood pressure is blocked. So what is observed is a beta 1 mediated small rise in blood pressure, and this is followed by a fall in blood pressure which is due to beta 2 mediated vasodilatation. So the epinephrine in presence of alpha blocker shows a small rise in blood pressure which is due to beta 1 mediated effect, and this is followed by a prolonged fall in blood pressure due to beta 2 mediated vasodilatation. Now this is known as vasomotor reversal of Dale, and this was demonstrated by Sir Henry Dale. This is a reversal phenomenon because an initial rise in blood pressure with epinephrine is not seen in presence of an alpha blocker. So what is observed is a fall in blood pressure which is the reversal of the initial effect. So this is known as the vasomotor reversal of Dale. That is the reversal of the initial phenomenon. The initial phenomenon was a rise in blood pressure, but in presence of an alpha blocker, a fall in blood pressure is seen, which is reversal of the initial effect. So now that we have seen the effect of epinephrine alone, and the second situation where epinephrine is administered in presence of an alpha blocker. So what is the effect of epinephrine when administered in presence of a beta blocker? Now when a beta blocker is administered prior to epinephrine, an initial rise in blood pressure is seen. The rise in blood pressure is due to alpha 1 mediated action, which is vasoconstriction and rise in peripheral vascular resistance, raising the blood pressure. But since beta 1 receptors are blocked, the beta 1 effect is not seen, and the rise in blood pressure is less than that of epinephrine alone because of lack of beta 1 action. There is no fall in blood pressure. The rise in blood pressure is not followed by a fall in blood pressure. This is because of blockade of beta 2 receptors which causes vasodilatation. So blockade of beta 2 receptors is responsible for absence of biphasic response, which is a rise in blood pressure followed by a fall in blood pressure. But in this case, fall in blood pressure is not seen because the beta 2 receptors are blocked. So only a rise in blood pressure is seen, and this is due to alpha 1 mediated action since the beta 1 receptors are already blocked. So now that we have learned the effects of epinephrine on blood pressure and heart rate, so let's study the effects of norepinephrine on blood pressure and heart rate. So let's start with the action of norepinephrine on various adrenergic receptors. Norepinephrine stimulates alpha-1, alpha-2, beta-1 receptors. It lacks beta-2 action. So norepinephrine does not exhibit beta-2 action. Norepinephrine has predominant action on alpha-1 receptors. Alpha-1 receptor stimulation causes vasoconstriction and a rise in peripheral vascular resistance, leading to a rise in diastolic blood pressure, since the diastolic blood pressure is dependent on peripheral vascular resistance. So the diastolic blood pressure significantly increases and the systolic blood pressure also increases due to beta-1 mediated action of norepinephrine. So norepinephrine causes a rise in blood pressure due to alpha-1 action, which causes vasoconstriction, and beta-1 mediated stimulatory action, which increases the cardiac output, stroke volume, and thus increasing the systolic blood pressure. So both diastolic blood pressure and systolic blood pressure increases. So this significantly increases the mean arterial pressure. So there is a sharp rise in mean arterial pressure compared to epinephrine, and because there is a sharp rise in blood pressure, the baroreceptors are activated and this sends the impulses to the vasomotor center. So the parasympathetic system is activated, increasing the vagal discharges and lowering the heart rate. Rise in mean arterial pressure leads to activation of baroreceptors, which increases the vagal discharges and lowering the heart rate, resulting in reflex bradycardia. So the effect of norepinephrine on heart rate is bradycardia. So to sum up, norepinephrine increases the diastolic blood pressure, which is due to peripheral vascular resistance, increases the systolic blood pressure, which is due to beta-1 mediated action, increasing the cardiac output. The mean arterial pressure significantly increases, which leads to baroreceptor activation and a decrease in heart rate. So the net effect on heart rate is bradycardia. Also, norepinephrine does not demonstrate vasomotor reversal of Dale, and the re-reversal of vasomotor reversal of Dale is also not seen in case of norepinephrine, because norepinephrine does not have any action on beta-2 receptors. So beta-2 mediated vasodilatation is absent and only a rise in blood pressure is seen. So let's compare the other effects of epinephrine and norepinephrine. The effects of epinephrine on peripheral blood vessels. Epinephrine causes vasoconstriction of the blood vessels of the skin, mucosa, renal blood vessels and splanchnic circulation, while it causes dilatation of the blood vessels of the skeletal muscle, the blood vessels of the heart, that is coronary blood vessels, and the cerebral blood vessels. So the blood volume is diverted from the splanchnic circulation to the muscles, heart, and increase in cerebral blood flow. So epinephrine administration helps to improve the blood flow to the brain, heart, and skeletal muscles. Norepinephrine, on the other hand, has marked vasoconstrictor characteristics. It has predominant action on alpha-1 receptors, increasing the peripheral vascular resistance and decreasing the blood flow in the peripheral circulation. So talking about the metabolic effects of epinephrine, epinephrine increases the metabolic rate, increasing the workload on the heart, the oxygen consumption increases, the glucose output increases, more glycogen is broken down to glucose, and also there is formation of lactic acid. So lactic acidosis can result from excess of epinephrine. But these metabolic effects are insignificant with norepinephrine use. With respect to the therapeutic uses, epinephrine is the drug of choice for the management of anaphylactic shock. By acting on alpha-1 and beta-1 receptors, it restores the blood pressure and increases the heart rate and helps to maintain the vitals. By stimulating the beta-2 receptors of the bronchial smooth muscles, it increases the diameter of the airways, increasing oxygen uptake and relieving respiratory distress. Also, by stimulating the beta-2 receptors of the mast cells, epinephrine decreases the release of histamine and is useful in the treatment of anaphylactic shock. Norepinephrine, on the other hand, is the drug of choice for the treatment of septic shock, which is characterized by poor vascular tone, vasodilatation, and a fall in blood pressure. So, norepinephrine, having marked vasoconstrictor action, helps to raise the blood pressure due to predominant action on alpha-1 receptors, increasing the peripheral vascular resistance, restoring the blood pressure, and is very useful for the treatment of septic shock, which is a vasodilatory type of shock. Next, we move on to the hemodynamic effects of dopamine. Dopamine at lower dosages stimulates the dopamine receptors of the renal blood vessels and splanchnic blood vessels, increasing the renal blood flow and splanchnic circulation. At medium dosages, that is 5 to 10 microgram per kilogram per minute, dopamine stimulates the beta-1 receptors of the heart, increasing the heart rate, contractility, thereby increasing the stroke volume, cardiac output. This improves the cardiac performance. Dopamine at higher dosages, that is more than 10 microgram per kilogram per minute, stimulates the alpha-1 receptors of the peripheral blood vessels. This significantly increases the peripheral vascular resistance, and increased peripheral resistance is undesirable in states of low cardiac output, because in these situations the systemic vascular resistance is already high. Increased peripheral vascular resistance also increases the afterload and increased workload on the heart, and this can trigger the incidence of myocardial ischemia and arrhythmias.
These are my references. Thanks for watching. Please like, subscribe and share.